As a continuation to the previous video in supracondylar fracture, differential diagnosis between extension type of supracondylar fracture and posterior dislocation of elbow. First of all, the common stage is totally different. We said before that all types of supracondylar fracture occur usually in children, while posterior dislocation of elbow much more common and usually occur in adults. Why? Extension type of supracondylar fracture in children and posterior dislocation occur in adults. The relative strength between bone and joint in different ages. In supracondylar fracture, the elbow joint is relatively stronger than the weak infantile or bone in children. Therefore, when the patient fall on outstretched hand with the elbow slightly flexed, this leads to closure fracture of the weak bone. In contrast, in adult life, the bone is strong and the humerus here is stronger than the elbow joint. Therefore, when the patient fall on outstretched hand with the forearm flexed, the weaker joint dislocate and the stronger bone is not fractured. That is why dislocation occur usually in adults, because in this age the joint stability is weaker than the strong bone, while in children the bone is friable, very weak in relation to the stability of the joint. In any fracture, there is limitation of movement, painful limitation of active movement. But in the operating theater, under anesthesia, the doctor can move the limb because there is a joint and there is access for movement. Therefore, in fracture, there is painful limitation of active movement, but passive movement is intact. While in dislocation, ask the patient to move the limb. He can't move the limb. And during anesthesia, in the operating theater, if the doctor try to move, the joint doesn't move because there is no access of movement. Therefore, in posterior dislocation, there is absolute loss of active and passive movement. Palpate anteriorly. If you palpate anteriorly, you will feel the sharp edge of the proximal fragment. In posterior palpation, you will feel the olecranon projecting backward, like posterior dislocation. Therefore, there is projection of the olecranon backward on both extension type of supracondylar fracture and posterior dislocation of the elbow. While in supracondylar fracture, posterior palpation will show the sharp edge of the distal fragment in addition to the projecting olecranon. Anterior palpation on supracondylar fracture, there is sharp edge of the proximal fragment. Anterior palpation in dislocation show what? Show the rounded lower end. shows the rounded lower end of the humerus, opposite the elbow crease, this crease in the elbow region, opposite the joint. Therefore, anterior palpation will show the rounded lower end of the humerus at the joint line, which coincide with the elbow crease. While anterior palpation here will show the sharp edge of the proximal fragment above the elbow crease because the fracture is above the joint. Therefore, anterior palpation and posterior palpation is characteristic. The relation between the three bony points. What are the three bony prominences in the elbow? Three bony prominences in the elbow. There are three bony prominences, which are medial and lateral epicondyles and posteriorly the olecranon. During complete extension, the 3 points lies on a straight line, while during flexion of the elbow, there is equilateral triangle between the 3 bony points, lateral, medial epicondyle and olecranon. This is the relation in extension straight line, equilateral triangle during flexion. In case of fracture, these are the relations during extension and flexion. In supracondylar fracture, which occur here above the medial epicondyle, lateral epicondyle and olecranon, the relation is normal because the fracture doesn't affect lateral or medial epicondyle or the olecranon. But in this location, the olecranon is displaced backward. Displacement of olecranon backward leading to disturbance in the normal relation between the 3 bony points. If under anesthesia, try to move the part, crepitus will be felt in case of fracture, and no crepitus felt in this location. Finally, feel here. What is this? This is supracondylar ridge, lateral and medial supracondylar ridge. In this location, disease of joint. If you palpate on the medial aspect and you palpate on the lateral aspect, the supracondylar ridge are felt normally. But sure, in fracture, if you feel laterally and medially the supracondylar ridge is intact, sure there is interruption of the supracondylar ridges. Measurements are very important. Measurements. The arm is measured from the acromion process to the lateral epicondyle, while the forearm is measured from the lateral epicondyle to the styloid process. In case of supracondylar fracture, the distal fragment is displaced upward and backward. Upward means shortening. This shortening will occur in case of supracondylar fracture in the arm or in the forearm. Sure, in the arm. Therefore, there is shortening in the measurement between acromion process and the lateral epicondyle. While in this location, the olecranon and the ulna displaced backward. If you measure the arm from acromion to lateral epicondyle, normal. What is the shortening? Shortening in the forearm from lateral epicondyle and styloid process. Imagine if radius and ulna for Wahdan displaced here, backward. Sure, the distance from lateral epicondyle to styloid process of radius is impaired. On the bone, this is the measurement of the forearm from lateral epicondyle to styloid process of radius. If radius and ulna elbow joint dislocated upward and backward, sure, the styloid process ascend upward with shortening in the distance of the forearm between lateral epicondyle and the styloid process. Therefore, we should notice that supracondylar fracture is disease of arm with shortening of the distance of the arm from acromion to lateral epicondyle, while dislocation of elbow is disease of forearm with shortening of the distance of the forearm, which is from lateral epicondyle to styloid process. Sure, diagnosis of fracture and dislocation occur by plain X-ray is the sure diagnosis, which here shows the dislocation and here will show the fracture. In this type, this is the extension type, the distal fragment towards the olecranon. Displaced backward towards the olecranon, which means the extension type. While here the distal fragment is displaced away from the olecranon, forward in relation to the proximal fragment. Therefore, this is a flexion type. Therefore, we know flexion and extension type in lateral view by if the distal fragment displaced anteriorly away from the olecranon, this flexion type. If the olecranon and distal fragment displaced posteriorly in relation to the proximal fragment, which is anterior, this is the extension type. What is the treatment of this patient? According to displacement, if undisplaced fracture, no manipulation, no reduction, fixation in posterior slab. Posterior slab with collar and the cuff. Sure, we all know collar and the cuff from previous fractures. Therefore, posterior slab with collar and the cuff for about 3 to 4 weeks. In case of displaced fracture in children usually treated by closed reduction and external fixation under general anesthesia and X-ray control. During in the operating theater and under X-ray control, traction is applied on the arm. This is a fracture and there is upward displacement and shortening. Therefore, traction in the long axis of the arm with counter traction on the arm to correct upward displacement. By traction in the long axis of the arm and counter traction on the arm, we correct upward displacement and shortening. Then gradual extension of the elbow to examine the carrying angle and to correct the carrying angle. That's to say, to correct medial or lateral displacement, because carrying angle is present only during extension and obliterated during flexion. Therefore, we extend the limb and examine the carrying angle and correct side to side displacement, medial or lateral displacement. Then Push the fragment forward or backward according to the type. Sure, in extension type, which is 99%, the bone is displaced backward. We should push the distal fragment forward. And in rare flexion type, we push the distal fragment which is displaced forward against the line of deformity backward. Therefore, by traction and counter traction, we correct upward displacement, then push the distal fragment forward or backward according to the type to correct anteroposterior displacement, and extend the limb to correct the carrying angle. During correction of this fracture, always put your hand on the radial pulse to maintain the radial pulse field to avoid Volkmann's ischemic contracture. This patient should be fixed after this reduction by posterior slab. Normally, in extension type, we fix the limb in flexion. We fix the limb in extension. To stretch triceps behind the distal fragment. During flexion, and the triceps is stretched to support the fracture from behind. But there is a drawback for this position, which is fixation in flexion, due to prolonged kinking of the brachial artery. And this may be predisposed to Volkmann's ischemic contracture. Therefore, many surgeons fix a supracondylar fracture in extension to avoid kinking of the brachial artery. But the standard technique is posterior slab from the axilla to the metacarpophalangeal joint with flexion of the elbow, and after application of this slab, the patient should be preserved in the hospital for continuous observation of the radial pulse to avoid Volkmann's ischemic contracture. In children, if closed reduction fails, we may fix the fracture like this. Reduction and the fixation of the fracture in children by wires. In adults, open reduction and internal fixation is recommended for all cases of adult by plate and screws. Open reduction and internal fixation is recommended in adults for early movement to avoid stiffness of elbow joint. Rehabilitation in this patient is very, very important to move the elbow as early as possible to avoid stiffness of elbow joint. This is a supracondylar fracture and its treatment. Thank you for good listening and good luck.